positive breast cancer. So the topic is mainly on the adjuvant therapy, escalation and de-escalation. What is there in the future? So, there have been a lot of options for a HER2 positive breast cancer. There have been attempts to reduce it, and there have been attempts to increase the number of agents. So, we will look into both the uh, strategies which have been used with good evidences. So, so we all know that early breast cancer outcomes have substantially improved over last 20 years, even though in the Indian setting, because we don't have routine mammographs being done as a part of screening, we pick a little bit of less early breast cancers. We pick up more of locally advanced breast cancers where we see a nodal disease. However, a significant proportion do present in a non-metastatic fashion, and that's the reason why we are able to cure majority of non-metastatic breast cancers. So, if you look into adjuvant therapy of a HER2 positive breast cancer, so we attempt on one end to give more stronger agents, more potential agents, longer duration of therapy. We want to use combination of anti-HER2 agents on one end, whereas on the other end, we will try to give lesser duration of therapy, lesser agents, and even spare some patients from chemotherapy. So this is the de-escalation approach. So the ultimate aim is to make the patient free of cancer with the least possible side effect I can give to the patient. So for the adjuvant chemotherapy part, we are having anthracycline, cyclophosphamide, and paclitaxel or taxane being these three drugs being the backbone of any breast cancer chemotherapy, and we have anti-HER2 agents being present in combination with this for the HER2 positive breast cancer. So HER2, so we spoke of ER positive, we spoke of triple negative, and now this is HER2 positive. So among the three, ER positive is the best because they are hormone positive, they are low grade tumors. You can see the luminal A and luminal B. So basically, they are sort of ER positive tumors. They do better than the basal. The basal is the yellow one, which is very bad because we don't have a proper target in it. So the way oncology is growing is we are trying to find out targets in any cancer. You take lung, you take breast, you take kidney, everywhere we are looking into targets, the mutations which are there, the driver mutations which are there in each cancer, and target that particular mutation. And this is helping us to improve outcomes in cancer patients. So luminal A, luminal B are sort of hormone receptor positive. We are able to target these with anti-hormonal therapy. Therefore, we are able to improve outcomes. Whereas if you come to HER2 positive breast cancer, HER2 positive breast cancer also has a target, and if you can target that, its outcomes are also in par with the hormone receptor breast cancer. But if you do not target, in itself, HER2 is a poor prognostic variant. So, HER2 positive is as bad as triple negative breast cancer if I don't give a drug that targets this particular mutation. But if I can target it, the outcomes are in comparison to that of luminal A and the B types. So HER2 positivity, yes, is a poor prognostic marker. But if I can target this with effective anti-HER2 agents, their outcomes are incomparable to hormone receptor positive breast cancer. So it all comes about finding out the target and giving the most potent drug to this particular target. So this is so in oncology we have so many targeting molecules. We heard of molecules like sacituzumab govitecan. We heard of uh, uh, pembrolizumab, we heard of atezolizumab. In oncology, there are very few molecules that has revolutionized cancer care. Among that, I think trastuzumab tops the list, where it has changed overall survival. It has added life to the patient. So there are majority of oncological drugs improve quality of life. They cause some responses. They give some progression-free interval. But we have very handful of drugs that actually change the natural history of disease. Among them, trastuzumab tops the list. So you can see all the three classical trials. I think any oncologist, when he goes through the medical school, these are the start trials that we go through: the HERA trial, the NCCTG, the BCIRG6. So you can see that all the three trials, if I can add this drug trastuzumab, that is anti-HER2 antibody, how beautifully it adds life to the patient. You can see the hazard ratios being consistently good in all the three trials. So we have this particular molecule that has actually revolutionized breast cancer management. It is because of this particular drug we are speaking so much on escalation and de-escalation strategies. So So then again, to look into which subgroup benefits the best in a HER2 positive breast cancer, age doesn't matter, whether younger or older, whether the primary tumor is bigger or doesn't matter. So all the subgroups benefit. However, an advanced stage and a hormone receptor positivity are sort of prognostic markers among the HER2 population. So So what? So if you look into a breast cancer, we always speak that yes, breast cancer is a localized disease. I operate it and I'm done with it. Why do I need adjuvant chemotherapy? Why do I need to give chemotherapy? So it is said that once the size of the breast tumor is more than 0.5 centimeters, it becomes a systemic disease. We will be able to detect cancer cells in the blood. Therefore, any tumor more than 0.5 centimeters becomes a systemic disease, and these patients need systemic therapy. So, if you look into a very small tumor, T1A or T1B tumor, that is less than 2 centimeters or so, if you look into the risk, so HER2 positivity in itself is prognostic. So if the patient has HER2 positive and you have not given anti-HER2 therapy, their outcomes are inferior to that which are HER2 negative. So HER2 in itself has a negative prognostic influence. This is the trial. So as I was saying you, active chemotherapy drugs for a breast cancer is anthracycline, cyclophosphamide, and taxane. Among these, we are always concerned of anthracycline. The reason is cardiotoxicity. So anthracyclines are more toxic when compared to the taxane combination. So our entire effort is to eliminate taxane in this HER2 positive subgroup, eliminate anthracycline. So the reason why we want to eliminate anthracycline is trastuzumab and anthracycline share a similar toxicity profile, that is cardiotoxicity. So there has always been an attempt to eliminate this anthracycline from majority of breast cancer treatment trials because of the shared toxicity profile. Uh, we also call anthracycline as a poor man's trastuzumab when trastuzumab was expensive. However, in the era where trastuzumab is affordable by majority of patients, there has been always an attempt to eliminate anthracycline, which is cardiotoxic, from the breast cancer management. So in this select subgroup, what we call as uh, the Tolani trial or the APT trial, where this was a phase 2 trial, this was not a randomized trial. They included breast tumors that had less than 3 centimeters and node negative disease, a very early tumor, which we come across during practice. In these trials, what he did was he eliminated anthracycline completely. So he gave 12 cycles of trastuzumab plus paclitaxel, followed by trastuzumab for 1 year. what is known as an anthracycline free regimen. So this was practice changing in that he showed an excellent disease free survival, 3-year DFS 98%, and whether it is HR positive or HR negative, there is a little bit of difference, but you can see the intent to treat population DF is 98% at 3 years and 93% at 7 years. So what I can say is you cannot improvise beyond this. 98% DFS is too much. So if I add an anthracycline, I won't be able to improvise beyond this. So therefore, above all, the guidelines have more or less accepted that anthracycline can be safely eliminated from the breast cancer adjuvant regimen if the tumor size is less than or equal to 3 centimeters, less than 3 centimeters. So if we have a T 3 centimeter or less than 3 centimeter breast tumor, anthracycline free regimen using paclitaxel plus trastuzumab for 12 weeks followed by trastuzumab for 1 year, the standard of care, because of this excellent 3-year disease free survival. Then going on, uh, well, if I give targeted therapy, the cells become resistant to it by various mechanisms. By reducing the expression of these receptors, we do see in around 10 to 15% patients, as the tumor progresses, a HER2 positive disease may become a HER2 negative disease. So in these resistant, trastuzumab resistant population, we have what is known as edotrastuzumab, or what we call as the TDM1. So this is basically an antibody drug conjugate. So we want to we use antibody, that is trastuzumab, that goes and attaches to the HER2 receptor, and there is a thioether link, and there is a chemotherapy moiety which we call as M-tansin being attached to it. And this M-tansin is lethal to the tubules in the cells. So I am using trastuzumab not just to kill the cell by targeting the HER2 receptor. I am also using this so that I attach an active chemotherapy drug to its tail by a linker, what we call as a payload, and then I will make these payloads or these chemotherapy drugs reach the target. And once trastuzumab attaches to the HER2 receptor on the surface, these active chemotherapy drugs get inside the cell and they kill the target cells. So it is a double purpose. Trastuzumab in itself reduces HER2 signaling, and secondly, this chemotherapy moiety gets inside the cell and eliminates the target cell. So this is what we call as an antibody drug conjugate. So this is a phase 2 attempt trial where uh, they found this TDM1 to be quite effective in the trastuzumab resistant population. So they wanted to eliminate chemotherapy also from the adjuvant chemotherapy backbone. However, this trial was a negative trial in that, so the baseline characteristics were well matched, but you can see here that um, the disease-free survival was almost similar between the two arms. The antibody drug conjugate did not prove superior to the paclitaxel plus trastuzumab regimen. However, the toxicities were also not that better in the TDM1 arm compared to the paclitaxel trastuzumab arm. Therefore, this is not practice changing because it was not better in its efficacy nor it was better in its toxicity profile. Therefore, adjuvant trastuzumab in an early breast cancer, adjuvant TDM1 in an early breast cancer is not the standard of care. Even today, the Tolani et al., that is paclitaxel trastuzumab followed by trastuzumab maintenance, is still the standard of care in the adjuvant treatment of breast cancer that are less than 3 centimeters. So now that we have understood how to treat a smaller breast tumor in a node negative disease where we can use an anthracycline free regimen, now we will look into what are the new adjuvant therapy options in a HER2 positive breast cancer. So why use new adjuvant therapy? So the There were all well accepted reasons which we all read in our undergraduate schools. If I give neoadjuvant chemotherapy, I will shrink the tumor. I can have a higher best breast sparing or breast conservation surgery. I will be able to handle the micro metastasis, and I can have some biological selection which subgroup is progressing or not. So very importantly, after the Catherine data, before the Catherine data, neoadjuvant chemotherapy did not add to survival. That is, giving chemotherapy before surgery did not add life to the patient. It only shrink the tumor. It only changed a modified radical mastectomy to a breast conservation surgery. So this is what it did. Or if the surgery dates were delayed, I could use this in the meantime just as a window so that the disease does not progress. But after the Catherine data, what neoadjuvant chemotherapy, neoadjuvant therapy in breast cancer has become little revolutionary. So I give a trastuzumab based neoadjuvant anti-HER2 therapy. After that, operate the breast and see what is the amount of efficacy of this drug by looking into what is known as pathological complete response. If the neoadjuvant chemotherapy has eliminated all the cancer cells in the operated tissue, what we call as pathological complete response, I would continue with trastuzumab maintenance alone. If the cells have not died, there are viable cells. If I have not attained a pathological complete response, I will escalate my treatment with a better drug, that is TDM1, which I just discussed before, and this has added life to the patient. So with this strategy, I will be able to select out those patients in whom giving trastuzumab alone will not be sufficient. I can add life to the patient if I can give a more potential drug in those subgroup where there is no pathological complete response. In other ways, I will be able to improve life of a patient if I can give new adjuvant chemotherapy than giving adjuvant chemotherapy. Therefore, if I have a tumor more than 3 centimeters, as a rule, we must offer neoadjuvant systemic therapy, trastuzumab based neoadjuvant systemic therapy in all patients. Not that neoadjuvant anti-HER2 therapy adds life directly, it indirectly helps in selecting patients who are not going to do well. It selects patients who do not attain a complete pathological response, and in these subgroup patients, I will be able to augment my adjuvant therapy by giving TDM1. So therefore, neoadjuvant anti-HER2 therapy has become very popular and has almost been accepted as standard of care in locally advanced breast cancer or a breast cancer that is more than 3 centimeters. I will look into the trial. I will explain you the trial in after a few slides. So, well, this is the what I said was pathological complete response. There has always been a debate: should my endpoint be pathological complete response? Endpoint should be overall survival. So, why is a pathological complete response a surrogate marker? See, these adjuvant trials are where the events, the patients are not going to die soon. They're going to live, they're going to have their normal lives. So, keeping overall survival as an endpoint needs a longer follow up. So, when I have an active drug and I want a longer follow up, for example, 5 years, 7 years, I will not be able to give this active drug for the coming 5 to 7 years. So, having these surrogate endpoints like pathological complete response, you can see in this particular, there has been a good correlation between a pathological complete response and event free survival. You can see the red and the green curves. If I have a good PCR, if I have a PCR, the event free survival is far better than not having a pathological complete response. You can see these barred charts, the blue, purple, yellow, and green. So if I add trastuzumab in a hormone receptor positive versus hormone receptor negative, so the highest pathological complete response is in the yellow, That is, I have given trastuzumab to the patient who is HR negative, HER2 positive, which is the highest, followed by next higher pathological response in those patients who received trastuzumab in HER2 positive, HR positive patients. So to simply to say that if I add trastuzumab, we are increasing pathological complete response rates, and this pathological complete response correlates with event-free survival. So, who should be considered for preoperative systemic therapy for HER2 positive early breast cancer? Any tumor more than 2 centimeter, more than or equal to 2 centimeter is what the guideline says. So, however, Tolani did mention that up to 3 centimeter I can do. But if you look into the inclusion criteria of the Catherine trial, even they have included tumor size more than 2 centimeters. So in the present era, if you're coming across early breast cancer, T size more than 2 centimeters, HER2 positive, we must offer new adjuvant therapy because I can add life to these patients. So these are the new adjuvant trials we have. This is an attempt to add pertuzumab. So pertuzumab plus trastuzumab uh, is what is a dual HER2 blockade. So if I add more HER2 blockade, dual HER2 blockade, do I add life to the patient? This is what we have. If I am adding dual HER2 blockade, trastuzumab plus pertuzumab. So these two act at two different receptor levels. Pertuzumab prevents heterodimerization of HER2 receptors. If I am adding a dual HER2 blocker, that is pertuzumab plus trastuzumab, I will be able to increase the pathological complete response rates, which is a surrogate for event-free survival. Therefore, there is a role for dual HER2 blockade in the new adjuvant systemic therapy of HER2 positive breast cancer. So this is another data from the Trifina study again, where dual HER2 blockade using trastuzumab, pertuzumab, along with chemotherapy improves pathological complete response rates. Remember, pathological complete response rates are highest in a hormone receptor negative population when compared to HR positive population. Then coming on to the adjuvant therapy part. So we spoke of adjuvant therapy. First part we spoke of adjuvant therapy in a low risk disease. Second part we spoke of new adjuvant therapy in a locally advanced disease. And we said that new adjuvant therapy should be given in patients who have a breast tumor size more than 2 centimeters. And now we will see what is the adjuvant therapy in high risk HER2 positive early breast cancer. So this is what we have. We have a tyrosine kinase inhibitor coming over here, neratinib. Then we have pertuzumab plus trastuzumab, the famous and now a little bit infamous Affinity Trial. And then we have the TDM1, which is the Catherine trial, which has changed practice. So let us go to the clinical evidence with each of these drugs. This is the Affinity trial where, so we looked into the neoadjuvant, the Trifema study, where if I could add dual HER2 blockade in the neoadjuvant setting, I could improve pathological complete response rates, which is a surrogate for event-free survival. Here they have used dual HER2 blockade in the adjuvant setting. So adding dual HER2 blockade, yes, has a bit of benefit, but not that great. I have a hazard ratio of 0.76. So in the node positive cohort, little bit more benefit, whereas in node negative cohort, there is not much benefit. Therefore, combining trastuzumab plus pertuzumab, dual HER2 blockade is beneficial, especially in a node positive subgroup and not in the node negative subgroup. So the invasive disease-free survival by HR status in the intent to treat population, we can see in the HR positive subgroup, hormone receptor positive, the hazard ratio is 0.73 and HR negative it is 0.83. So little bit of counter evidence is that the long-term follow-up of the affinity data, the overall survival benefit is not there. So dual HER2 blockade in the adjuvant setting, because of lack of OS benefit, has sort of become obsolete right now because of lack of long-term OS benefit. And that's the reason why we can give an accelerated approval, there is no problem, but we have to have a long term data where it has not reflected for overall survival, probably because the magnitude of benefit we had was very small, and this hazard ratio of 0.8 is not that great to offer a overall survival benefit. So, however, it is not compulsory to have trastuzumab plus pertuzumab combination in patients of high risk. If I am giving it, I will be giving it in a node positive patient and not in a node negative patient. So, safety is reasonably fine with pertuzumab. It doesn't add too much cardiotoxicity. Then, coming on to neratinib, which is a HER2 TKI. So neratinib is a pan-HER TKI. It just doesn't inhibit the HER2 receptor from outside. It's an irreversible pan-HER TKI. It has a mechanism of action different from pertuzumab and trastuzumab. So neratinib was given post completion of 1 year of trastuzumab in node positive and also node negative disease. You can see that early breast cancer stage 1 to stage 3 were included in this, and the primary endpoint was invasive disease free survival. And the dose was 240 milligram once a day for 1 year. And you can see the 5 year invasive disease free survival has a hazard ratio of 0.73 and significant p value 90 versus 87% at 5 year invasive disease free survival. In the HR positive subgroup, the hazard ratio is 0.6. In the HR negative subgroup, the hazard ratio is 0.95. So HR positive subgroup shows a better hazard ratio. Neratinib, when added post completion of 1 year of trastuzumab, improves invasive disease-free survival. Therefore, adding neratinib is sort of an augmentation. It adds extra life to the patient after completing 1 year of trastuzumab. So you can see the benefit without PCR, the delta becomes 7.4%. Then this is the Catherine trial, which is the practice changing trial right now. We have, so let us go into the details of the study. So this particular trial was an international randomized open label phase 3 trial. It included HER2 positive breast cancer. You can look into the inclusion criteria. It had T1 to T4 and N0 tumors, and who had residual disease in breast or axillary nodes after new adjuvant HER2 directed therapy. The randomization was TDM1, standard dose for 14 cycles versus trastuzumab for 14 cycles. The primary endpoint was invasive disease-free survival. Secondary endpoint was distant disease-free survival and overall survival and safety. So if you look into the type of cancers they had, you can see that 75% had operable disease. So if a HER2 positive patient comes to you, operable, still you can offer new adjuvant therapy based on the inclusion criteria of this particular trial. You can see in nearly 80% there was trastuzumab alone, and in rest 20% there was dual HER2 blockade used. So even if you give pertuzumab plus trastuzumab in the new adjuvant setting, this particular trial included 20% of those patients, and you can see an excellent invasive disease-free survival difference with a hazard ratio of 0.5, which we hardly see in oncology. So TDM1 given what we call as augmentation of adjuvant HER2 therapy based on pathological complete response rates. In those patients where there was no pathological complete response, if I can augment the adjuvant therapy with TDM1 than continuing trastuzumab alone, we have a 3-year invasive disease-free survival, which is statistically different, and the hazard ratio is 0.5. Then you can look at all the subgroups, HR positive, HR negative, whether I have used pertuzumab, or trastuzumab alone, node positive, node negative, all the subgroups have benefited, and the hazard ratios are more impressive. And you can see in the node negative subgroup, the hazard ratios are much more impressive than the node positive subgroup. And remember, 75% of patients were operable breast cancer as per the inclusion criteria of this trial. So these are the secondary endpoints: distant recurrence and overall survival. Of course, overall survival are quite immature. We need to have a long-term follow-up, but distant recurrence is again statistically significant. And hazard ratio for OS is also 0.7. So these are the class side effects of TDM1, transaminitis, fatigue, low platelet count, and discontinuation was required in 18% patients. So then quickly going through further, so eliminating chemotherapy completely using TDM1 plus pertuzumab in the adjuvant setting did not show great benefit. So this says that I cannot eliminate taxane trastuzumab chemotherapy. I have to use, even if I use the most expensive drugs like pertuzumab plus TDM1, that is not the way to go. I need to use trastuzumab plus taxane in the adjuvant setting. So this is the patient-reported outcomes we have, and this is the Christian trial. This is again the similar thing. I cannot omit taxane trastuzumab, even though I have TDM1 and pertuzumab in my hand. That is what the trial is saying. So this is another excellent study. This is so we saw anthracycline-free regimen in early breast cancer of T size less than 3 centimeters. Here we have anthracycline-free new adjuvant chemotherapy regimen where they have used double HER2 blockade with pertuzumab, trastuzumab, and they have used paclitaxel plus carboplatin in the new adjuvant setting. And this trial has clearly showed that we may get away without anthracycline if I am using a double HER2 blockade in combination with paclitaxel and carboplatin. So train 2 is another practice changing trial. I can eliminate anthracycline not only in early breast cancer, I can eliminate anthracycline even in a locally advanced breast cancer if I can use dual HER2 blockade with pertuzumab plus trastuzumab, and I use paclitaxel plus carboplatin in the new adjuvant regimen because the pathological complete response rates were comparable. So that is about eliminating anthracyclines. Quickly going through the slides. These are the new trials. So what we can do right now, these are the proposed management. So if I have a T1A-B tumor size less than 3 centimeter, I'm okay using an anthracycline-free regimen, paclitaxel plus trastuzumab for 12 cycles weekly, followed by trastuzumab for 1 year. So if I have a locally advanced tumor, if the tumor size is more than 2 centimeter or more than 3 centimeter, more than 2 centimeter as per Catherine, we must give, if possible, the black box inside is not visible. So what is written is dual HER2 blockade should be included if feasible as a new adjuvant regimen, because we could see the trifema data where if I can use pertuzumab plus trastuzumab plus chemotherapy in the new adjuvant, I can improve pathological response rate. If there is complete pathological response, continue the same anti-HER2 regimen which I use in neoadjuvant setting, and I can add neratinib for 1 year after completing the standard anti-HER2 therapy. So neratinib 1 year 240 milligram OD has improved invasive disease-free survival. If there is residual disease, we have to augment the HER2-directed therapy by adding TDM1 because we have data on based on Catherine data with a hazard ratio of 0.5. So that is about augmentation and elimination trials which we spoke of, and this is the ongoing trials which we have, and this is a summary. So the similar thing, less than 3 centimeter anthracycline free, more than 3 centimeter give neoadjuvant therapy. If I want to eliminate anthracycline, give dual HER2 blockade. So moving a little bit away from HER2 positive, we had Createx study where adjuvant CAPE who did not have PCR did benefit. So this is a metronomic dose of capecitabine where they have used irrespective of PCR, and even this has shown some benefit. And these are the differences between Createx and this metronomic capecitabine trial. However, so what I can get from this particular trial is giving a lower dose continuous capecitabine is also feasible because it is less toxic. So, so the whole purpose of treating early breast cancer is to have the best anti-cancer, our best cancer survival and best cancer outcomes with least possible toxicity which we can have. So these are some Mind Act trials that we have. This was basically the MammaPrint data where they have further analyzed. So MammaPrint data did meet its primary endpoint of predicting, being prognostic of which subgroup chemotherapy can be avoided. This is something like Oncotype DX. They used distance metastasis-free survival as an endpoint. So yes, it is prognostic. Mind Act is prognostic, but its predictive value is not that great to that of Oncotype DX. So this is another alternative trial where they used new adjuvant hormonal therapy in ER positive patient, and they tried to look into reduction in Ki67. However, this was not a positive trial, still not practice changing. So with this, I will come to the conclusion of the trial with few take-home messages. So what are my take-home points today? So HER2 positive disease has a poor prognostic influence, definitely. But if I can give good HER2 directed therapy for an optimal duration, I can definitely improve outcomes in HER2 positive patients. Secondly, if I have a T size more than 0.5 centimeter, this is no longer a localized disease, this is a systemic disease, and I must give systemic therapy. If the T size is less than 2 centimeters, I'm comfortable eliminating anthracycline completely, and I can give a taxane and trastuzumab based regimen alone. If the T size is more than 2 centimeters, even if the breast is operable, I should not be operating the breast. I should be giving neoadjuvant HER2 directed therapy. If possible, a dual HER2 directed therapy in the neoadjuvant setting. If there is a complete pathological response, I can continue trastuzumab maintenance for 1 year, followed by neratinib for 1 more year. It has shown benefit. If there is no complete pathological response, we must be using TDM1 in the adjuvant setting for 1 year because of improvement in invasive disease-free survival. And then in the neoadjuvant setting, I can omit anthracycline if I can use a dual HER2 blockade plus paclitaxel plus carboplatin as per the train to study. So with this, there has been a lot of options in HER2 positive breast cancer. So with this, I would come to the conclusion, and I would thank everyone for their patient listening.